So actually tonight I'm going to talk about CMV and solid organ transplants. That's the topic. I'm not going to talk about other transplant topics. We're trying to, when we do the talks, when my group does the talk, we're going to try to do a couple of transplant topics. But I thought CMV would be a good one to start with, since it's so common and we have to deal with it so frequently. So, is the right thing here? Okay, so everybody knows about CMV. It's a member of the herpes family. It's a double-stranded DNA virus. And a lot of people have been exposed to CMV by the time they're young adults. About 50% of the population will be positive for CMV in the United States by the time they're young adults. Worldwide, in some countries, it's a lot higher, up to like 90%. But we're not going to talk about that group of immunocompetent or the kids that get CMV. We're going to talk about the transplant population and how CMV affects them. So let's first go over a couple of definitions. So you should understand the difference between CMV infection and CMV disease. So CMV infection implies that you have active replication of CMV, of the virus. And if you use various methods, you could actually measure virus. And you can look for virus in one of several ways. We used to do viral cultures a long time ago, and that's all that we had. They took a long time, usually weeks. They were very labor intensive. Then we started doing antigen testing, and we tested for the pp65 antigen. But now we pretty much do nucleic acid testing. So we detect CMV DNA or CMV RNA by PCR methods, and that's really pretty much the test of choice nowadays. Now, CMV disease is somebody who has CMV replication but also has symptoms of disease. So they may they could have just a mono-like illness or a CMV syndrome. A lot of the patients who are mismatches early on, they may only get a CMV syndrome. So that would be a syndrome of a mono-like illness with fever, chills, maybe leukopenia, thrombocytopenia, or you can have CMV tissue invasive disease. And those patients get actual end organ, infection. So they may have CMV gastritis or CMV hepatitis or pneumonitis. So CMV infection, where you just have replication, versus disease where you have replication with signs and symptoms of CMV disease. And really, CMV can infect just about any organ. So CMV is actually the most common viral infection in solid organ transplants. And without prophylaxis, 75% of recipients could get CMV disease. It tends to occur more commonly in lung and intestine transplants, then heart and liver, and then kidney actually is the least affected. So why would you think that lung and intestinal transplants have a higher risk of CMV disease? Anybody have any thoughts on that? Right, so lungs, they need more intensive immunosuppression. And actually, intestines, they get more lymphoid tissue transplanted, so that's why they have a higher incidence. And then heart and kidney, and then heart and liver, and then kidney the least. And so how can patients get CMV disease? Well, they can get the virus when they're transplanted. So if you have somebody who is CMV negative and then they get a CMV positive organ, they can get primary CMV infection. They can have reactivation if they're already CMV positive, then they can get reactivation of their own CMV, or they can also get a superinfection with CMV from donor cell reactivation, which is actually something I didn't really appreciate. You kind of don't think about it, but you could get that, and then it's hard to figure out or discern whether the CMV came from someone's own reactivation or from the organ, but that apparently has been described. Without prophylaxis, CMV tends to occur early after transplant, so within like the first 3 months after transplant. Now, with prophylaxis, we've pushed back CMV disease to 3 to 6 months after transplant. So when the patients get through with their prophylaxis, then they get their CMV disease. So now we're seeing what's called late CMV in patients who get prophylaxis. So what does CMV do? What's when it infects somebody who's had an organ transplant? Well, CMV apparently has a predilection to invade the allograft, and they think it's due to an aberrant immune response within the graft itself. So the graft itself is not capable of a good immune response, so CMV tends to invade those cells. And it can also have numerous indirect effects by modulating the immune system. CMV has also been associated with other infections like bacteremia, fungal infections, EBV, lymphoproliferative disease. And CMV is also an important contributor to acute and chronic allograft injury. So in kidneys, you can get chronic allograft nephropathy, or what's called tubulointerstitial fibrosis. In lung recipients, it can contribute to bronchiolitis obliterans, and in heart transplants, it can contribute to coronary vasculopathy. So you don't just get the illness from getting CMV, from getting the CMV disease or infection. You could also have effects on the allograft itself, even in terms of chronic allograft injury. So it's important to look at patients and donors when they come to you for their risk factors for CMV. So these are some of the risk factors in the recipient to acquire or get CMV infection. So the worst is if you don't have CMV, of course, and then you get a CMV positive organ. Then you're at the highest risk, and also you're at the highest risk for the most severe infection. The patient's overall state of immunosuppression, so depending on what immunosuppressive regimen they're on, you can see on the bottom it says drugs like sirolimus, which is Rapamune, is actually associated with a lower risk of CMV compared to other immunosuppressive agents. Host factors like people of advanced age that may have a little more immunosuppression because of age. If somebody has a problem with chronic leukopenia or neutropenia, they may be at higher risk of getting CMV because their overall immunosuppression is a little bit greater just because of host factors. Possibly other things like ischemic time, patients being critically ill for prolonged periods of time. They also are probably a little more immunosuppressed. Transplant type, which we talked about. Now, if you have somebody who's CMV negative and they get a negative organ, they're at the lowest risk of acquiring CMV. And in those patients, we should try to make sure that they get CMV negative blood and blood products after transplant. So all donors and transplant candidates are screened, and the best test to screen for is serology, and that serology being IgG. So it's really not useful to screen with IgMs. And a lot of times IgMs will be falsely positive. So really, sometimes the transplant centers, they order it, and then you get this IgM that's positive, and then everybody's, wondering, what do we do with this? Well, usually those are false positive IgM, so it's really recommended that we screen donors and recipients with only IgG. Then what do you do with if you have a donor or a recipient whose CMV serology is indeterminate or borderline? What do you do with those patients? So you don't know if they're positive or they're negative. So if you have a donor who is CMV, if their CMV serology is borderline or indeterminate, so really you're gonna really think of what's the most conservative scenario. So you're going to be, you're going to err on the side of being more aggressive rather than less aggressive. So if the donor is borderline, then basically you're going to consider them as a positive donor. Okay, so say their CMV IgG comes back and it's indeterminate, you're going to consider that donor positive. If the recipient is borderline or indeterminate, then you're going to assign the most conservative approach. So if the CMV serology is positive for the donor, then you're going to consider the recipient negative and treat them like a mismatch. If the recipient, let's see, if the donor's CMV is negative, then that recipient will be considered seropositive if they happen to be indeterminate. So again, you're going to take the most conservative, most aggressive approach and always err on the side of, being more aggressive in those patients. Also, patients who receive lymphocyte depleting drugs, that would be like thymoglobulin, antibody therapy for either initial immunosuppression or rejection, they should also be considered very high risk for acquiring CMV disease. Okay, so how do we look for CMV? Well, we kind of talked about this a little bit earlier. We can look at histology, so that's actually getting tissue. That's not really practical in everybody because it's invasive, and you may be able to make the diagnosis in other ways, but sometimes you do have to do histology. So if you have a case where you suspect CMV disease, but the blood serology or the blood PCR is negative, then those patients may have to have a biopsy. And that would be true, I think I've seen it the most in GI disease, where people have CMV colitis, or CMV, esophagitis, where actually the blood PCR may be totally negative, but when you biopsy the patient, they have evidence of CMV on their histology. I think that's really the main place that I've seen that. You should also do histology when you think there might be another process there. Maybe you think they have CMV, but maybe you're also thinking about another co-pathogen or another process. So in those cases, you may have to do histology. So occasionally, we'll see that again, mostly I think in GI disease. So here's some examples of CMV. The top two are H&E stains, and people have described this as looking like owl's eyes. I think everybody's heard that, and actually this sometimes shows up on the boards, slides of CMV and the owl's eyes. So those were two good examples, and then the bottom one is immunohistological staining, where the bright kind of round cells are actually CMV. So really the preferred method now, like we said, is molecular testing, where you're looking for CMV DNA or CMV RNA. And actually CMV RNA is very indicative of active CMV replication. The DNA can be extra sensitive. So you may see a positive CMV DNA in somebody who just has latent CMV, but it tends to turn positive very early, and you can quantify the DNA so that it makes it very useful for diagnosing very early CMV replication. So pretty much CMV DNA by quantitative NAT testing is the method that's used to detect CMV. If patients have a lot of virus, then they're more likely to have CMV. If they have low-level viremia with the DNA test, then they're more likely just to have low-grade replication or latent CMV. But here we use the CMV DNA test. So there was a lot of studies looking at the quant test. It's done in a lot of labs. The problem is everybody has like a different standard, where a different cutoff, and also they have different methodology. So you could get a CMV PCR here, and you could get one at Quest, and they could be very different. And they can be up to 3 logs different on the, that's the slide, 3 log variation in the different assays. So it's important to get the test done at the same lab every time if you're really trying to compare or monitor a patient during therapy. Again, if they have a very high viral load, it's more likely they have CMV disease. Also, if you have a rapid rise in the PCR. So maybe you have somebody that has a very low level PCR, maybe like, just a couple hundred, but then a week later they have 10,000. So you can look at that as well. You can look at the rise, and if it's a rapid rise, it's more indicative of CMV disease. So what is the quantitative NAT useful for? It's useful for guiding preemptive therapy, which we're going to talk about. It's useful for very early and rapid diagnosis of CMV. And then you can use it as a guide to treatment response, just like our HIV viral loads, where we monitor people's viral load. Same thing with the CMV PCR. You want to see the viral load coming down and then eventually becoming undetectable. And again, you can't compare different assays. So we see that happen a lot in the heart transplant clinic, because they get their PCR here, and then they live in Port Charlotte, so they go to Quest, for their follow-up, and then it's hard to figure out to compare them, because they can be very, very different. So how do you prevent CMV disease? Our main thing that we want to do in transplant patients is to prevent the disease, because if they get it, of course, they can get very ill, especially if they have primary CMV. So there's a lot of information in the literature on how to prevent CMV disease. So there's really 2 strategies that can be used. You can use prophylaxis, or you can use preemptive therapy. So prophylaxis would be you give the patients antiviral drugs after transplant for a defined period of time to prevent CMV disease. Whereas preemptive is you monitor the patients with intermittent viral load tests, and when it becomes positive, then you treat them. So you're basically monitoring them for any evidence of early CMV replication with the goal of preventing disease. So we have prophylaxis, where you give everybody drug, and then we have preemptive, where you monitor patients and only give them medication if you start to see CMV replication. So these are some of the characteristics of prophylactic versus preemptive therapy. So efficacy for prophylaxis, there are large randomized trials that show that prophylaxis does work. There are some studies for preemptive therapy, but they're smaller, and there's very few in the mismatch patients. So really, preemptive therapy is really not recommended for patients who are CMV mismatches. It's more for patients who are already positive in certain organs, and we'll talk about that. Prophylaxis is a lot easier because you just give them a prescription and they go to the store and they get it and then they take their prophylaxis. Whereas preemptive, you have to have transplant coordinators who make sure that the patients get their CMV PCR every week and that somebody follows up on it. And then if it turns positive, there's someone to go to ask them what to do with this. So it's a little more labor intensive in terms of having good follow-up. And also in the preemptive, the viral load thresholds are not standardized, so that's another kind of sometimes an issue. Late CMV disease occurs commonly in people who get prophylaxis because, again, you're just putting off, especially in a mismatch, you're just really putting off the CMV primary infection till later, till down the road. Whereas with preemptive therapy, it occurs less commonly. Costs, there's higher drug costs in the prophylaxis group, but higher laboratory costs in the other group. There's a little bit more drug toxicity in the prophylaxis group because they may be on drug longer, there might be more marrow suppression. And then in terms of indirect effects, there have been some studies not studies, but meta-analysis that have showed a positive impact in the prophylaxis group on things like graft injury later, but there's very limited data on preemptive therapy. And then with both, you can get CMV, you can get drug resistance. But we'll go over what we actually do here at Tampa General. So here's a couple studies that looked at which drug to use and also length of time. How long should you give someone prophylaxis? So the first study was in kidney, liver, pancreas, and heart patients. And these were 372 CMV mismatched patients, and they randomized them to either oral Ganciclovir or oral Ganciclovir for prophylaxis, not for treatment. So they found that actually the rate of CMV disease at 12 months was comparable in both groups. So whether you use Ganciclovir or Ganciclovir, it was about the same. The second study was a study in kidney transplants where they looked at length of therapy or length of prophylaxis. So they compared 200 versus 100 days of prophylaxis in mismatched patients. And they saw that the evidence of CMV disease was higher in groups that got the 100 days of prophylaxis versus those who got 200 days. And in that study, they all got Ganciclovir. So in that one study, longer was better. These are some studies in some lung recipients, and they also looked at length of time of prophylaxis in lung transplants. And generally, they found that if they were treated for less than 6 months, they had a higher incidence of CMV disease. So, and that patients who got at least 6 months did better, had lower incidence of CMV disease. And then there was a recent study of CMV donor positive, recipient negative, and also donor positive, recipient positives who got 12 months of Ganciclovir, and they did much better than those who got only 3 months. So they compared 12 months versus 3 months, and there was a much lower incidence of both viremia with CMV and also with CMV disease. But then in other studies, there's been some where even despite 12 months in lung, they still didn't do as well. So you can see the data's kind of mixed, but it seems to favor longer therapy rather than shorter in lung transplants. So we talked a little bit about late CMV, so that's CMV disease after somebody finishes their prophylaxis. So that requires that we monitor patients very carefully, that we do virologic monitoring when appropriate, and in some cases, it occurs more commonly in people who have prolonged antiviral prophylaxis. So recommendations, Ganciclovir is the drug of choice for CMV prophylaxis. It's easier to take. It has much higher bioavailability than Ganciclovir. Patients should start early, at least within the first 10 days of transplant. So you don't have to worry about when you see the person in CSU and they're day one getting them on their prophylaxis. You can have up to 10 days to start them on medication. If they can't start on oral, you can start on IV Ganciclovir and then switch to Ganciclovir once they're taking, PO. CMV prophylaxis is generally not recommended for CMV donor negative, recipient negative, except for in one instance, which I'll go over, but they should get CMV negative blood. And then the dose is 900 milligrams once a day compared to twice a day for treatment. For prophylaxis, it's just once a day. And alternatives are IV Ganciclovir or oral Ganciclovir. And for kidney only, occasionally they use Valacyclovir, but that's for kidney only, and that's probably because they have a much lower risk of CMV disease. We don't really recommend that at Tampa General, but it is in the literature and could be considered, especially if you had maybe a patient that just couldn't get Valacyclovir for some reason. So here's our protocol. We have it broken down by organ and then by their donor and recipient serology. And probably everybody has a copy of this when we send out the transplant guidelines. Does everybody have that? Yeah, okay. So let's look at kidney liver. So if you're a mismatch, donor positive, recipient negative, then you get 6 months of antivirals. If you're just R positive, it doesn't matter what you get, whether you get a negative organ or a positive organ, you get 3 months of antivirals. And then for kidneys that are negative to negative, they just get regular HSV prophylaxis. Now, livers who are negative to negative, they actually get 3 months of CMV antivirals. And why do you think that is? Does anybody know? I'm like, why do they get prophylaxis if they're not getting a positive organ and they're negative? Well, the reason is that they get so much blood products that they have an increased risk of getting primary CMV. So in the livers, they're going to get 3 months of CMV antiviral therapy. Okay, then in heart mismatches, they actually get 6 months of antivirals plus CMV immunoglobulin. And there's a specific schedule for that, how much and how often. I don't have that committed to memory, but that does exist. So they are actually going to get both antivirals and CMV immunoglobulin. Now, if you have a heart transplant that is recipient positive, they're the group that's allowed to have preemptive therapy. And that's really the only group that we use preemptive therapy in at Tampa General. So those patients are monitored by the transplant coordinators and get regular CMV PCRs, and then if they turn positive, they get treated. And then the lung heart, they're the group that you're going to give very long prophylaxis for. So a mismatch gets at least 12 months. Sometimes they give longer, plus CMV immunoglobulin. The recipient positive gets 6 months of antivirals. And then liver, pancreas, and pancreas, you can see 6 months and 3 months. So does anybody have any questions about the Tampa General protocol? This is pretty much what we use here. All right, so preemptive therapy, what do you have to do? Well, you have to monitor the patient. They get CMV PCRs every week for 12 weeks. And then if they go above a certain threshold, which is usually center specific, then they get treated for CMV. If they do go above that threshold and need treatment, then therapies Ganciclovir 900 BID or IV Ganciclovir 5 milligrams per kilogram Q12, of course, adjusted for renal function. How long do you treat them? You treat them till they have at least 2 negative CMVs a week apart, and usually it's usually at least 3 weeks of treatment. So you monitor them every week. There's no need to do CMV PCRs more often. Once a week is enough. You don't have to do them every couple days. It's just recommended to do it once a week. And then once they have 2 negatives, they can switch over to secondary prophylaxis. So they would go back to Ganciclovir 900 once a day once they finish their therapy. So any questions about that? No.
Has there been any cost-effectiveness analysis comparing these?
I don't know the answer to that, actually. So I'm not sure about that. Does anybody else know?
For our program, no.
Yeah, I don't know if there's any information in the literature. I didn't come across anything about it, but That's a good question.
What's our threshold here for, because it's center specific?
So the cutoff here is 200. So they'll say greater than 200 or like less than 200 detectable or undetectable. So we use 200. Now that's, I think, low. So some places use 500, some use 1,000, some use 3,000. We've kind of looked at when they turn positive or get above our 200. I think if you had a patient that you didn't think was a really high risk and maybe it was like 250, it wouldn't be unreasonable to monitor those patients and do a viral load every week. And then if it starts to rise rapidly, then treat them. If it goes down, then not. So I think you could kind of tailor that to the patient. Do you guys have any comments about that? I don't know if you do it different in the lungs or... It's a very difficult question to answer. And when I was preparing this talk, I actually looked that up because, there's no consensus about what the threshold should be. So... Now, during treatment with antibody like thymoglobulin, whether you use it for treatment or initial immunosuppression or treatment of rejection, remember we said that that's a major risk factor for CMV disease. So those patients should be considered to start back on antiviral prophylaxis. So if you have somebody who maybe they're 6 months out and now they have an episode of rejection and they need thymoglobulin, they should go on antiviral prophylaxis from somewhere between 1 to 3 months. At Tampa General, we recommend 3 months, but in the literature, it says you can you consider 1 to 3 months. If somebody gets thymoglobulin right out of the box, so they get a heart, they maybe have some kidney issues, they have to stop the calcineurin inhibitors, they put them on thymoglobulin, those patients are going to get antiviral prophylaxis. So if they're R positive and they get put on thymoglobulin right away, then instead of HSV prophylaxis, they're going to get CMV prophylaxis. So that's a common scenario in the CSU here where that happens. Also, there's a lot of discussion about what about patients who get treated for rejection with high-dose steroids? Should they go back on prophylaxis? And some people feel that they should. We don't really have a rule about that here, but it is not unreasonable to consider prophylaxis for CMV in those patients that are on high-dose steroids for rejection. And also maybe also PCP prophylaxis or PJP, which I've never gotten used to. Do they have to change that? Okay, what about treatment of CMV? Well, for treatment, we should use IV Ganciclovir or Ganciclovir. You should not use oral Ganciclovir to treat CMV disease. You can consider it for prophylaxis, but not for treatment. If somebody has mild to moderate CMV disease, you can use Valacyclovir, but if they have severe disease, they should get IV Ganciclovir. And sometimes also CMV immune globulin, especially if they have a life-threatening infection like CMV pneumonitis or something like that. They should be treated for at least 2 to 4 weeks till their CMV PCR is negative. Usually it's going to be at least 3 weeks of treatment, and then they need to go on secondary prophylaxis after that. And then you're going to monitor their CMV PCR during that time. If possible, you should talk to the transplant surgeon or transplant nephrologist or cardiologist about trying to reduce immunosuppression, if that's at all possible. And sometimes it is. Sometimes they can reduce the immunosuppression in some of these patients that get CMV disease. So I just put Ganciclovir in here because there's a couple slides on resistance, so I thought we'd just talk briefly about Ganciclovir and how does it work. So Ganciclovir is an acyclic analog nucleoside of the nucleoside guanine, and it has to be converted intracellularly to a monophosphate form by a viral kinase, and that kinase is encoded by the CMV-UL97 gene. So that's one of the places where you can get resistance. If you get a mutation of that gene, you'll get a mutation that will affect that viral kinase. And then once that happens, it's catalyzed to diphosphate and triphosphate. And CMV actually has two mechanisms, or Ganciclovir has two mechanisms of action. It can be a competitive inhibitor of deoxyguanosine triphosphate, which is incorporated into DNA, and therefore it inhibits viral DNA polymerase. or it can serve as a poor substrate for chain elongation, kind of like the HIV nucleosides, where they, they interfere with chain elongation by substituting for a naturally occurring nucleoside. So it has these two mechanisms of action. And Ganciclovir is really just I don't know if the prodrug is the right name, but it's converted to Ganciclovir. I guess it would be. It's a prodrug of Ganciclovir. It's rapidly converted, and you get much higher levels. So you can see that the bioavailability is tenfold greater than oral Ganciclovir. So 900 milligrams of Ganciclovir gives you the same systemic exposure as the IV Ganciclovir, 5 milligrams per kilogram. So how does CMV develop Ganciclovir resistance? Well, you can have a mutation at that viral kinase gene, the UL97, and then CMV also competitively inhibits Ganciclovir also competitively inhibits CMV DNA polymerase, and DNA polymerase is encoded by the UL54 gene. The UL97 mutation is much more common, and resistance tends to occur in sequence, where you get the UL97 mutation first, and then you get the UL54 later. So they don't come kind of randomly. The 97 occurs first. It's the most common, and then the 54 can come later. So it's a sequential thing. If you get the UL97, you can usually use foscarnet or a Cytomegalovirus to treat CMV disease. They're both very nephrotoxic. We used to use these a lot in HIV when people got CMV retinitis. We didn't have, Ganciclovir then, and we used systemic drugs, so people got IV foscarnet and IV Cytomegalovirus. But renal toxicity is really, can be a problem. Usually if the patients get the UL54, they may be resistant to all drugs. So with the 97, you have a couple options, but if you get the UL54 mutation, you may not have any options. And how do you figure out which mutation they have? Well, there is a genotypic assay available. There's also a phenotypic assay available for CMV, but it's recommended that you use the genotypic assay because that actually tells you what, where the mutation is. But actually, the incidence of resistance overall is fairly low. You can see it occurred in 1.9% of those receiving oral Ganciclovir for 3 months, and in one study, no one receiving Ganciclovir prophylaxis, but it has been described in lung transplants, and it's probably more common in lung transplants than other organ transplants. And maybe at the end you can comment, Jose or Beata, you can comment on that, because you guys do the lungs. So who should you worry about for CMV resistance? Well, if you have people, the longer they're on oral prophylaxis or the more times they have to be on prophylactic therapy, the higher the risk of developing resistance, kind of just a lot like HIV. The people that are mismatches, they have a higher risk of resistance. And then also if they have increased immunosuppression. Again, lung transplants are more common. In one study with preemptive therapy in lung transplants, there was about a 2.2 incidence of resistant CMV. So what do you do if somebody has resistant CMV? Again, you're going to do that genotypic test, which is a send-out but available at Tampa General. Cautious reduction of immunosuppression if possible, and switching to a sirolimus-containing regimen. If that's an option, you could consider increasing the IV Ganciclovir dose to 10 milligrams per kilogram BID. But remember, that's associated with, with myelosuppression, so you're going to have increased myelosuppression, or a full dose foscarnet. And then there are some oral drugs that may be available by compassionate basis. So these are drugs in development that, and they're oral. And possibly you could get them on a compassionate basis, and I listed them. I've never gotten any. We did do a study at Tampa General with the maribavir. We didn't end up enrolling anybody, but we did have a study here using that for people that had resistant CMV or refractory CMV infection. You could also consider using CMV immune globulin, again, especially in patients who are very ill. So these are my references. I really recommend that you look at that American Journal of Transplant. The Infectious Disease Guidelines issue is from March of 2013. It's a really good issue, and It has excellent articles on not just CMV but any infection you could think of, pretty much in transplant patients, and it's very condensed and to the point, and they give you specific recommendations, so you're not reading a lot of extra. It really gives you concrete, useful things that you can use in patients. And then there's a couple other references that I use.